Professor Taccone, who will speak to us about the management of coagulation.
Thank you. Thank you for the introduction. I will try to launch my presentation. Thanks for being here. So coagulation management in severe TBI, I have some conflict of interest, but not related to this lecture. So I think we talking a little bit about trauma, but my focus is more on traumatic brain injury, and we know it's a devastating disease with a burden of poor neurological outcome in these patients. And as an intensivist, we've been fighting over the years to find a kind of a magic bullet, kind of drug that is able to reverse this tremendous brain dysfunction. And as you know, we have failed many, many times in all these intervention because the pathophysiology of TBI is very, very complex. So as an intensivist, what we can do now basically is trying to minimize secondary brain injuries. And the secondary brain injuries are basically related in some part to extracerebral brain aggressions related to the dysfunction of different systems that are associated with the occurrence of traumatic brain injury because of this interplay between the brain and the extracerebral systems. So the topic is coagulation, and of course, as the heart, the lungs, and the kidneys, when you have a traumatic brain injury, independently of the polytrauma or isolated injury, you might have disturbances of the homeostatic mechanisms. And these are basically coagulopathy. Everyone knows coagulopathy. There should be also a place for hypercoagulability, which is much more complicated to manage. And I cite this systematic review, which is a little bit outdated, but has been repeatedly confirmed in its conclusion by following observational studies, where the occurrence of coagulation disturbances after TBI is around a third of patients, with a huge variability between 10 to 90% according to the definition that has been used in the study to define these coagulation disorders. So why this is important? Of course, you can imagine that if you have a coagulopathy, as traumatic brain injury is associated with contusion and intracranial hemorrhages, the presence and the size of this hemorrhage, and even their progressions, are main determinants of poor outcomes. You may imagine if you have a coagulopathy, this might favor the progression of this hemorrhage. And on the other side, many traumatic brain injury patients, particularly severe cases, suffer from secondary ischemic insult. And it is possible that the main macrohemodynamics, as Mathieu has underlined, the CPP is a main determinant, but also microvascular injury that is also influenced by these microclots and hypercoagulability might also be an important issue. Of course, you may say, well, we observe this alteration. Are these just a marker of severity? The most severe patients are more severe hemostatic disturbances, or it's something that is independently associated with poor outcome? It's an important question because as we can measure coagulation at bedside, a little bit in a gross way sometimes, but we can measure it, well, we have therapies that can potentially modify these coagulation disorders. So, of course, the question is this intervention could be amenable to change the coagulation profile and potentially change patients' trajectories. So, of course, I'm not an expert of coagulation, but the concept in traumatic brain injury is the same that in the trauma in general. So you have this release in tissue factors, von Willebrand, the activation of platelets at the subendothelial levels, and then you have the activation of the hemostatic system to create this clot that is stabilized. And, of course, according to the kind of disease that you have, you might have more and hypercoagulability with these macroclots and multiple organ failure, or on the other side, what we know much better, the excessive consumption of coagulation factors that, of course, will translate into an hemorrhagic situation. And you don't have to forget that it's in complex interplay, even the role of the different regulators of the procoagulants and anticoagulants pathways. I've just cited only a few of them, are extremely important, can be extremely disturbed in that situation. And why I present you this slide, because of course you may easily understand when you have a coagulation disorders after an isolated traumatic brain injury, you would like to intervene on some of those. You can intervene on platelets, on coagulation factors, on regulator factors, on all of them, trying to, of course, correct this coagulopathy. And, of course, if you're really interested in that topic, I recommend you this review from Miguel and co-workers on Latin neurology. It's 2017, just to show you how much more complex than the slide I just presented before is this coagulopathy in traumatic brain injury, starting from the initial injury, going through tissue injury, BBB disruption, complicated by sometimes hypoperfusion and shock. And you see all these complex pathways that are activated, ending with hemorrhagic contusion and progression of the hemorrhage and tissue ischemia. So you see, very complex, and if it is complex, of course you may easily understand how complex is the management of these coagulation disorders. So can we quantify coagulation at the bedside? Of course you might say, yes, we can. I usually do it at the bedside, APTT, PTT, fibrinogen. This is a sub-study from Center TBI where interested centers evaluated, much more in-depth coagulation disorder after an isolated TBI. So we're talking about isolated TBI. And they separate patients as a small cohort into patients with coagulopathy defined as an ENR bone 1.2 and no coagulopathy. And they showed, of course, that there are some alterations which are expected. But if you go much more in-depth, looking at different factors and different regulators, even the D-dimers and plasminogen, there might be differences across these different groups. So ENR is only a part of what you are looking, kind of the top of the iceberg, but if you go more in depth, then you are able to better quantify these disorders. And it's a bit tricky because the time that you receive these values, your patient is maybe progressing the hemorrhage. You are not selecting the adequate therapy because coagulation tests need some time to be done. And of course, there is a role for this viscoelastographic test that you can do at the bedside, at least the TEG and the ROTEM, where you look at the coagulation formation and the quality of coagulation clot. This is largely used in the trauma setting, of course, to sometimes titrate the intervention. If you are able, your lab is able to provide you this kind of aggregometry test when you use different inhibitors of platelet function, you can more adequately assess platelet function too. You have a more quicker and more adequate and complete view of the coagulation. The point, and this is the limitation for isolated TBI, is that it's not maybe adequate to look occult coagulopathy, very early phase, and you can consider that sometimes isolated TBI has an intracranial coagulopathy, which cannot be detected by doing, of course, systemic tests. So again, to show you that we are still limited, even if you use this test to adequately assess what's happening inside the brain. So now when you go to the management, the first question is, should we give platelets to patients with isolated TBI? So platelet dysfunction can be due basically by thrombopenia. There is a loss of platelets with polytrauma, or you have some platelet dysfunction triggered by the traumatic brain injuries, basically a dysfunction of receptors, or the patient is on antiplatelets drugs, aspirin on other drugs. So this is a recommendation from the trauma guidelines from SPAN and co-workers, say that you can give platelets if the platelets count is less than 50,000, the grade 1 recommendation, but the level C, the level of evidence, is based on good clinical sense. And the big question is, should we give platelets to patients with isolated TBI which are on antiplatelet drugs? This is the recommendation from the recent consensus made in the European Society of Intensive Care, published in Intensive Care Medicine, with Alexander Vlar being the first author, when they said, we recommend to have a restrictive platelet transfusions in that setting. Why this? Because this is based on studies on spontaneous intracranial hemorrhage, where 2 randomized small trials show that if you give platelets to patients with antiplatelet therapy at home, you don't improve the outcome of these patients. Of course, you might say traumatic hemorrhage is not the same as spontaneous hemorrhage, and there is an association of the presence of an antiplatelet drug with the progression of traumatic intracranial hemorrhage. So again, in the lack of randomized clinical trials, you might try to individualize the decision based on the severity of the injury, on the location of bleeding. If you have in the posterior fossa, you don't want it to progress too much, maybe would be more liberal in transfusions, and maybe the need of surgery. If you go to the OR because you need a drainage of an hemorrhage, put a catheter or whatever, if the patient he or she is on antiplatelet drugs, you might want to give platelets to reduce the risk that intervention can potentially increase the bleeding risk. Should we add to platelets desmopressin, which increases factor VIII and von Willebrand factors availability? Well, we have few studies showing that it reduces the need for platelet transfusion, but of course, because of the small side effect, it doesn't improve outcome. So it's open to the decision, but it's really something that is decided on the individual basis. Concerning coagulation factors, of course, we know that coagulation is basically due to consumption, but if the patient is on anticoagulant at home and the patient suffers from an isolated traumatic brain injury with hemorrhage, of course, we will reverse warfarin, it's very easy, or the new oral anticoagulants. This is part of the standard therapy of this TBI management. The point is that should I give prophylactic administration in isolated TBI, giving, for example, fresh frozen plasma, in the absence of anticoagulant therapy at home? So what we know now is that, of course, if you give these factors, you can correct a blood test. So if you have an ENR which is elevated, you give this to FFP, you will improve ENR, which is logical. You're just correcting the number. While there is no data in clinics in observational study clearly showing that this can have an impact on mortality. And even some studies suggesting that you may increase the risk of poor outcome. Of course, in the subgroup of patients with a huge hemorrhage, there might be a role in particular if they go to the operative room, and we are looking for biomarkers at the bedside that might identify patients with a higher risk of intracranial hemorrhage progression, and in few studies, high D-dimer, a low fibrinogen, has been used as the markers predicting this progression. So you might use high D-dimer and low fibrinogen in 3 hours to select the patients with isolated TBI where maybe FFP could be used more liberally than in the others. Should we give fibrinogen, which is extremely rapidly available? Again, it reduces blood products requirements, but of course we don't have randomized clinical trials, so we cannot recommend giving fibrinogen prophylactically to all patients with isolated TBI and intracranial hemorrhage. And of course, you might know, you might remember, I remember when I was a little bit younger, the use of activated factor VII. There is a randomized clinical trial in TBI showing that you can reduce the hematoma growth. Maybe you can go faster to the surgery, but there is no impact on outcome. And considering the cost and considering the fact that in isolated TBI, there might be also a procoagulation systemic situation where you can increase the risk of thromboembolic event, you might be wondering whether this is the good way to go, and clearly is not recommended in practice. Now, where we have more literature and where it's more controversial is the management, because treatment is inappropriate, the management of fibrinolysis. And as you know, the tranexamic acid is the drug that is able to control the plasminogen activation to plasmin, which of course have an alteration of coagulation. So giving tranexamic acid, you can have a procoagulant status aiming to reduce the risk of intracranial hemorrhage progression, and the CRASH-3 trials is the trial that specifically evaluated tranexamic acid in traumatic brain injury. Where does this come from? Of course, large literature looking at the role of TXA in different bleeding situations. You know, for example, the women's study in postpartum hemorrhage. And they have a CRASH-2 trial. The CRASH-2 trial is the trial that has basically prone the use of TXA in trauma patients. With polytrauma, it reduces the risk of dying in the early phase for bleeding. And they evaluated in the subgroup of patients with traumatic brain injury the fact that TXA might work. And in the next randomized analysis of the CRASH-2 trials, they found that if you give tranexamic acid, you reduce the extension of the hematoma growth. So it's, you spare 5 milliliters of progression of the hematoma. Does it matter in the brain? It depends where the hematoma is located. And when they looked at patients' outcome, there was, in that sub-analysis, an improvement in mortality and outcome. So this was a good basis to say, if in CRASH-2 has been working to reduce mortality and there is a signal in TBI patients, I might go for a large randomized clinical trial to show whether you can reproduce this data in TBI patients. And the CRASH-3 trials had basically tested the hypothesis that in adult TBI patients, within the 3 hours from injury, which shows the changes in the initial protocol with the GCS less than 12 or intracranial hemorrhage. If you give tranexamic acid, you can reduce the 28-day mortality, specifically traumatic brain injury-related mortality, as the primary outcome. And you see here this huge trial expected to include at least 10,000 patients. Now, these are the main results of the study. As you know, 12,000 patients randomized, 9,000 included within 3 hours, which is the subset of patients where the study was focusing, and they reanalyzed the data, excluding those with GCS of 3 and dilated pupils, saying these are patients that have no chance to recovery. And basically, these are the main results. Mortality is reduced by 1.3%, which is P of 0.06. So if you like numbers, you can interpret as you want. And in subgroup of patients where GCS 3 and dilated pupils were excluded, there was a significant difference in outcome between groups, not adjusted by baseline characteristics. And these are the numbers within 1 hour, number of patients with hypertension and number of patients with a mild TBI, showing that basically it was quite a huge population of patients representing quite adequately the TBI world. Now, if you look at the subgroup analysis, the authors claim that it doesn't work in severe TBI, but it works in patients with mild to moderate. So it should be given to all patients, in particular because it works in mild to moderate. Why? Because in severe patients, these are too severe that are unable to recover, which is totally false to my opinion. And they also show that as in CRUSH-2 trial, in the mild to moderate GCS, the earliest you give the drug, the more effective seems to be, while of course no significant effect of time to administration was observed in severe TBI patients. This study has been announced by the Lancet as a dramatically change in the management of traumatic brain injury patients because you can reduce the mortality. And the reasons why I've been invited to talk about this is probably because I've written with Giuseppe and Nino Stocchetti quite, controversial editorial on how this cannot crash the way that we treat TBI patients, because there are many other things that you have to consider. First, if you put all the data of tranexamic acid in traumatic brain injury all together in a systematic review, you can still not obtain this difference in outcomes in terms of mortality. So despite this huge trial, 10,000 patients, the effect on mortality remains limited. There is, after the publication, another randomized trial when the tranexamic acid was given even pre-hospital. So the patients were randomized to pre-hospital 1 grams or 2 grams, then giving in hospital or a totally placebo group. And they have 1,000 patients randomized in 3 groups. And when you combine all the tranexamic acid patients, you have this 3% difference in mortality, but no big difference in terms of neurological outcome. And Andrew Mas and other people have reanalyzed this data, including this paper inside, and still there is no statistical significant difference in the meta-analysis in terms of mortality difference in favor of tranexamic acid. And again, the possible concern about thromboembolic events remain uncertain. The authors say it's safe, but remains uncertain in these patients. The other point is that as a physician taking care of TBI, of course I'm interested in mortality, but what I want is the people go out alive from the hospital. So if I save life to have more dependent patients, that's not the way to go. And in this CRUSH-2 trial, they were unable to demonstrate any difference in terms of neurological outcome from tranexamic acid when compared to the placebo group. And the other point is that you should have some plausibility. You should be able to demonstrate that this drug works. And they basically have shown no progression of ICCH on the sub-study of patients where the CT scan is available after the admission. They have no data on coagulation. They have no data on patients only with intracranial hemorrhage. So it's quite complicated to understand how it works on mortality if they're not able to explain the mechanisms. And again, the point is that it might be very helpful in these patients. It might be probably helpful before surgery in that patients. I'm not sure it might be helpful in these patients with a diffuse axonal injury where the progression of the hemorrhage is not the issue to be treated. So what we have done is that we have tried to summarize what we do. In isolated TBI, what we do basically is that according to their results, we don't give in GCS with severe traumatic brain injury, but we treat in baby patients with a mild to moderate situation within 3 hours when pupils are reactive. So again, individualized care rather than giving to everyone. So the conclusion is that coagulation abnormalities are frequent after TBI. There is a limited role to give it prophylactic FFP, fibrinogen, and activated factor 7 to all patients. So it might be decided on individual basis, but to giving routinely to all patients, there's a limited role. In selected isolated TBI patients, there might be a role for tranexamic acid. And of course, much more research is required to better understand the phenotypes of our patients, the role of viscoelastographic test, and maybe in the future, because I discussed only on coagulation disorders in terms of coagulopathy, better understand the role of hypercoagulability and how to treat and manage this complication. Thanks.
So we would like to thank you for this excellent lecture, and I would like to invite questions from the audience.
No questions.
No, just one question.
Yes.
Yes. Could you please elaborate how ROTEM can give us data on platelet function when the platelet count is normal? Because I'm not familiar with the concept.
Yeah, I have to say that in my hospital, we're using ROTEM in the standard way. Let's say we do the clotting test, exactly. So if you want to use it, as the slide showed you before, you need to integrate the aggregometry. So you add heparin to remove the coagulation factors, and you add different agonists of the platelets, arachidonic acid or some others like ADP receptors. And you see how much platelets are functioning when these agonists are present. And it's very interesting because, again, you can find that people on antiplatelets drugs have totally normal platelet function. And also it's very interesting is that if you give platelets transfusion, you may not be able to totally reverse platelet dysfunction. So really titrate your intervention. But again, you require a laboratory which is able to give you the results quite rapidly. Or if you do it at the lab, you have, of course, this multi-plate assessment of platelets that we do routinely. But again, you need expert explaining how you interpret the data. And so we are still far to use this aggregometry test as a ROTEM in all the centers because it requires more manipulation. Yeah.
So I also have a question. There is no sub-analysis in the CRUSH trial about patients who were on anticoagulant therapy. So I presume that we should individualize again, but according to which targets?
Exactly. As you said, what is interesting that you give this drug to 10,000 patients, and you want to say that it works in everyone. And of course, the concept on how this drug works should tell you that it might work in some selected cases. Again, it's logical if you have an intracranial hemorrhage that you might have some effect, but it might be less logical in diffuse axonal injury. And as you said, we would have liked to have more mechanistic data to help us to understand how it works, because if it reduces mortality and you give a procoagulant drug, you are acting in reducing bleeding. I mean, in trauma it's logical, you reduce bleeding. In trauma, in isolated TBI, you should reduce the progression of hemorrhage. It's not a neuroprotective drug, it's a drug that acts on coagulation. So, from my point of view, if they were able to show that you have a reduction of progression of the hemorrhage, if you have less blood into the brain, it's logical you can save early mortality at least. It's not the case. They were not able to reproduce this data. So I have a lot of pro-con debate with Ian Roberts, which is a great researcher, by the way. You have to be commended, 10,000 patient study. But I have to say it's less straightforward that he wants to sell the idea. I think it's less evident to be effective in this patient population that has been presented in the main paper.
Dr. Taccone, I have one question. We stopped the hemorrhage, and now is the time for antithrombotic therapy. What do you take in consideration? What parameters do you take in consideration to start antithrombotic therapy? And what happens if you have a patient with severe traumatic brain injury and concomitant injuries, let's say pelvic fracture, if you use temporary IVC filters?
That's a very good question, of course. And as you know, people write the guidelines. When you see the guidelines and the reference, it's based on good common sense. So we have tried to implement a different recommendation that was part of the ESA guidelines. So we said basically in 48 hours with isolated TBI and no signs of progression of hemorrhage, we start low molecular weight heparin. But if there is a progression of the hemorrhage, if there is another lesion that is very high risk of liver injury or hemoperitoneum or whatever, then my hospital will use stocking compression, intermittent compression. And when it's not really possible because there are injuries in the legs, we have been using in the past even the percutaneous inferior vena cava filter. So I think you have different options, and you choose probably the less invasive one, or it's the most known one, like the subcutaneous anticoagulants in most of the patients, and you select additional possibility in those where you really feel uncomfortable to start the therapy. So it's, again, you should have more options and target according to the patients. And as you said, the case that you were presenting, it's exactly the case where we will discuss a lot the risk and the benefit to give a drugs, and I will probably go for intermittent peripheral compression.
Thank you very much.
Thank you.